Okay, we'll go ahead and get started, and welcome to Grand Rounds. You know, it's a good academic semester when we have not one, but two shared conferences with our friends in cardiology, and we're really delighted to have the second of those conferences today, and to welcome Venu Menon, who is a professor of medicine, also the Razavi Endowed Chair in Education at the Heart and Vascular Institute, section head in clinical cardiology, director of the Cardiovascular Fellowship, director of the Coronary Care Unit, all at the Cleveland Clinic in Cleveland, Ohio. Dr. Menon received his BMMS degree from Jawaharlal Institute of Madras University, and then completed an intern year there as well in medicine before joining our family, where he completed another internship, his residency, and his fellowship in cardiology, all at the former St. Luke's Roosevelt Hospital Center. And it's certainly a point of pride for all of us, Dr. Menon, that you're with us today and to get insights from your really distinguished career. Dr. Menon completed his training with a research fellowship in the NIH-supported shock trial that we're all very familiar with, and what it led all of us to conclude about the importance of early intervention in acute coronary syndromes. Along his way as a trainee, Dr. Menon was recognized while he was with us as the best junior resident, and also received the Michael Rockman Award for the best graduating resident from our residency. Subsequent to that, he's received 8 separate teaching awards, and perhaps most notably, has more than 230 manuscripts published in his field of expertise, and has a truly international following and recognition for his work in helping us to better understand the acute coronary syndrome. For instance, the role of type 2 diabetes in the management of patients with ACS, the lipoprotein, arrhythmias, and so on. Dr. Menon, it was really remarkable for me to review your very distinguished career and all that you've done to help us better the lives of patients presenting with ACS, making sure we intervene early. And we're delighted today to hear your thoughts about the importance of cardiogenic shock as it relates to COVID-19. And you'll be very aware, this is certainly something we saw in the last 15 months or so, and we'll be delighted to have your insights. So welcome, Dr. Menon. Again, a point of pride for us to have you with us. Thank you.
Dr. Menon, you're muted.
Got it. Thank you, Dr. Stewart. It looks like I still need some lessons in Zoom, even 1 year into what's a never-ending pandemic. But I really thought this was owed a debt of gratitude. And I wanted to start with this quotation that gratitude is when memory is stored in the heart and not in the mind. In many ways, although I've not been living in New York for over 2 decades, I think of the Upper West Side as home because that's where I feel most comfortable when I walk the streets. And so a lot of that has to do with my career, both as a trainee and for a few years as a young faculty at St. Luke's. And so for that, I am eternally grateful. In many ways, it is home because this is where it all started. For all of you folks, this is the building across from St. Luke's. And I landed up here on June the 17th, 1992 as an intern. And my home here was apartment 13D. And that's where I spent the next 5 to 10 years of my life. Along the way, did my internal medicine there as well as cardiology. And this is the wonderful group of people I had the opportunity to train with. And you can recognize some of the faces. If you can't, up front here is Dr. Jacqueline Tamis, who is still a fantastic attending there. And this was not a 3-year or 5-year connection. This was something that has endured over time. And as you can see, while we've lost significant hair and the skin has gotten older and we've all aged hopefully well, we remain the best of friends. And that's really, really important. And then clearly Jackie has been a dear, dear friend, and we stay in constant touch over the years. But while that was a part of my personal growth, I must confess that St. Luke's Roosevelt had a whole lot to do with who I became as a physician. I think when I look back, and I was fortunate that Dr. Norma Braun was on early. Just the folks like in the MICU, working with Dr. Braun, Dr. Bell, Mary O'Sullivan, Tony Abb. These were just fantastic, dedicated physicians, and I learned so much from them onto how to be a physician that it has influenced me over the rest of my life, and I'm eternally grateful for that. What I've shown here are, apart from there's a number of people here like Dr. Palazzo and Dr. Lipton who are still there and remain dear, dear friends. But I want to show two people who during my 10 years at St. Luke's really influenced who I went on to become. The first was Dr. Miles Schwartz, who was a program director of cardiovascular medicine and who recruited me to cardiology there. And I learned a whole lot from Dr. Schwartz. And the two things I will always remember from Dr. Schwartz is one was to dress appropriately on the service, to wear a shirt and a tie and never let your guard down. But the more important thing was to be available. He said, if you're a consultant, you need to be available and you need to be available 24/7. And I think that remains really, really important dictum that I let all my fellows know every year. But shown here on the left is someone I think who's really influenced who I have become as a physician and as a clinician was Judith Hockman. I came into St. Luke's with every intention to be an oncologist. And on June 17th, I got posted in the CCU, which was up on the 5th floor, I think in plant 5. And I distinctly remember I admitted 4 patients that night, and my first night as an intern. There was a patient who came in from Lincoln Hospital who had Chagas disease and had multiple PVCs. There was a lady who'd been out on Long Island and came in with complete heart block from Lyme's disease. There was a bread and butter infarction that we treated with fibrinolysis. And then there was a heart failure patient who came in with a huge degree of congestion. And I went on rounds with Dr. Hockman the next morning, somewhere between 8 and 10:30. And those rounds were so influential that by the end of the week, I knew that my intent to be an oncologist was now being seriously questioned, and I needed to consider cardiology. And in the course of the next 6 to 8 years, she gave me the opportunity to work with her on the shock trial. She gave me an opportunity to work in many, many areas that a person with my ability and my experience should not have had the opportunity. And for that, I'm eternally grateful. And, I think I'm greatly appreciative of that. So that being said, the area I worked with Dr. Hockman was in cardiogenic shock. And so I thought it was appropriate that if I came back to speak at St. Luke's, it should be on shock. And so given that this was a general audience of both heart failure, of both cardiology as well as internal medicine, I just want to give some brief vignettes and end up with a case in the era of COVID. So I think it's important to understand what the components of cardiogenic shock are. There's clearly hypotension, but all hypotension is not shock. When you combine that hypotension with tachycardia, you're getting an intravascular depletion or an ineffective cardiac output that's causing a compensatory response. Now, if that too is not shock, starts becoming shock that from a cardiogenic standpoint, when as a result of that, there's end organ hypoperfusion. And so when you have a person with a blood pressure of 80, who has an ejection fraction of 15%, who's been in class 3 heart failure all their life, they're looking at the ceiling, reading the New York Times, that's not shock just because they have a blood pressure of 80. I think this combination is what is to be recognized. And that too, in the setting of a adequate intravascular status. So I do think that it's important for young interns and residents to understand what constitutes shock. Now in the ICU, although we did most of our work on myocardial infarction, when you go to the CICU today, this is data from the CCTN registry, which is a registry of 30 hospitals around the country. We are one of them that really looks at research in the CCU. You can see that the etiology of shock even in the CICU is quite heterogeneous. And cardiogenic shock is only about 2/3 of all the shock you encounter in the CICU. And when you take a look at the causes of shock, it's not just acute myocardial infarction. It could be arrhythmia, it could be non-ischemic issues, it could be ventricular complications, just a multitude of things. So I want to keep that in mind as I go through my talk. So let's go through some broad lessons for a young trainee to consider in the management of cardiogenic shock once you've recognized it. The first lesson is that rapid establishment of a diagnosis is key. This is William Osler, I think someone we owe everything that we do in modern medicine in terms of how we approach the patient and how we plan for treatment. He did say that medicine is a science of uncertainty and an art of probability, and that remains true even today with all our imaging and genomic and other advances. There's three key things to effective treatment. That's first, get the diagnosis, get the diagnosis, and get the diagnosis. And so I think even in the setting of shock, the first question you need to answer is, why is my patient in shock? Nothing else really matters. Unless you know what the cause is, you really don't know what to do. And so I just highlighted that by showing you 3 cases of shock that I encountered at 3 a.m. in the morning. The first one is someone who comes in with frank syncope, and what you can see here is a large mass in the left atrium that the cardiology fellows will recognize to be a left atrial myxoma that's traversing the mitral valve, causing obstruction. This is the pseudo-mitral stenosis that you sometimes get in the ABIM. And you can see here, it's completely obstructing inflow to the left ventricle that is underfilled. So the cause of shock in this person is this large tumor, and the treatment here is that this tumor needs to be removed as soon as possible. Shown here is a 21-year-old patient who comes in with cardiogenic shock. And you can see here on the presenting EKG, a very bizarre rhythm of atrial fibrillation with the QRS complex that is extremely, extremely, extremely bizarre and really can't sustain electrical activity. Now, this person happened to be on a class 1 agent for paroxysmal atrial fibrillation and took this with suicidal intent. When you do the echo, you can see there's marked dyssynchrony of the ventricle causing a completely ineffective cardiac output. So what this person needs is that the drug is going to wash out, but we need a temporary window of time to support the circulation while we can get the drug to wash out. And what shown here is a third case, which a fellow calls me up. This is a person post-aortic valve replacement at 3 in the morning who comes in because they suddenly syncopized at home. When you do the echo, you can really see that the left ventricle actually appears a little underfilled, but the function is pretty good. The right ventricle is not collapsed, so there's no signs of tamponade. There's no pericardial effusion. The left atrium looks well preserved. But what you can't see here is the contours of the right atrium. And at 3 o'clock in the morning in an ICU room with the lights on, you can miss that. When you do a TEE, you can actually see that there is no right atrium, that there's actually a big hematoma that is compressing the right atrium. And so this is an example of localized tamponade. And this is also why I really find critical care cardiology a challenge, because recognizing something and doing something about it can sometimes mean a patient is alive and shaking your hand the next morning. In this case, we were unable on that first echo to recognize that the right atrium did not exist. And so this person actually arrested a short while after that TEE. And what you can see here is a large right atrial hematoma that's compressing the right atrium, causing localized tamponade, which was causing this patient's presentation. And this was because the patient had a prior aortic valve replacement, and the ventricular pledget here that we put in had actually come off. And so there was a slow ooze in the weeks after surgery that ultimately caused the right atrium to collapse and caused this dramatic presentation. So once you've established a diagnosis. You know what the problem is. Your next and sometimes simultaneous act is to support the peripheral circulation. One of the challenges that we have is that in correcting things, it's always too late. The liver is gone, the kidney is gone, the brain is gone. And so you may salvage the heart, but that's not the point, right? We want a patient who has a quality of life going forwards after the event. And so it's really important that while you're addressing the acute insult of the heart, you are able to target the peripheral circulation. And that's what's changed dramatically in the last 15 odd years. So in the late 1990s, when Jackie and I were fellows, if someone went into shock, the only way we had to support the ventricle was with an intra-aortic balloon pump. But over the last 10 years, we've had a number of devices, whether they're specific to the left ventricle, the right ventricle, or provide biventricular support that can provide really reliable temporary mechanical support for hours and days after an acute myocardial insult. This could be an ECMO, this could be a tandem heart, this could be an impeller, or even if you have a friendly surgeon, we could go on CentriMag support. And all of these various devices focus on either one side or the other side of the ventricle, unload the ventricle in various ways, but provide us an opportunity to provide ventricular-specific support. Now, that's just not for the left ventricle. You can do that for the right ventricle too. And I've shown you a number of devices here that we can use to support the right ventricle in the current era. So let's put that concept in play using some cases. So here's a nice bread and butter case. This is someone who comes in with chest pain, and all the residents in the room will recognize that this person's having an acute myocardial infarction. There's ST elevation in the inferior leads. There's reciprocal ST depression in 1 and AVL. And this is a pretty large infralateral infarction. And if someone can take a closer look, there's a little bit of ST elevation in V1 that suggests that the right ventricle may indeed be involved. So we take this patient to the cath lab, and sure enough, the proximal right coronary artery has a large globule of thrombus in it with TIMI 0 flow. You can't see the distal vessel. And so the friendly interventionist, as per routine, just goes on to do a reasonable intervention and restores flow in the infarct-related artery. Now, obviously, we were suspecting that this person might have a right ventricular infarction, and the best treatment for a right ventricular infarction is to open up the artery and restore flow. But normally, that restoration of RV function, while it can come pretty quickly, can sometimes take a while to occur. So here's the patient coming into the CCU after the right coronary is being taken care of. And you can see that the right ventricle is dilated and dysfunctional, consistent with an RV infarction. So clearly by the bedside, this person is going to be hypotensive, have very, very clear lungs, have an elevated JVD, and be peripherally hypoperfused. However, this patient is also profoundly hypoxic. And that's difficult to explain with clear lungs. And so when we do a saline contrast study, as shown in the bottom, the saline contrast actually goes into the left side, suggesting that in the setting of an RV infarction, the pressures in the right atrium have caused a PFO to open up and cause right to left shunting, which is a cause of VQ mismatch, and as a result of which we have hypoxia. So what do we do with this patient? In the past, we would have to just wait and wait and wait. Now we support the right ventricle if the need arises. And so this was one of those RP impeller devices that I showed you in the previous slide, a specific device to support the right ventricle. We do that for a day. The right ventricular function returns to normal. And here you can see on follow-up, the left ventricle is normal, the right ventricular function is now preserved. This patient is going to have an uneventful course. If it hadn't been for the support, we would have ended up with a person in renal failure, a person with a massive transaminitis, a liver failure. And so this is where I really think that these devices have played a pretty significant role in helping select patients. Here's another example of providing support. This is a TEE, so it's a little hard for folks to recognize. But on the TEE, we're showing the intra IVC, and you can see in the IVC is a large linear mobile structure, which happens to be an IVC thrombus. You can see this flow around this IVC thrombus, but this IVC thrombus is something that is arising as any astute medical, I'm sure most of the residents at St. Luke's, knowing how good they are, would say, hey, this person might have a renal cell cancer in the upper pole of the right kidney that's extending all the way up the IVC. And you can see not only is it extending up the IVC, the head of that clot is also in the right atrium. So here we are doing this transesophageal echo, taking a look at this, and time passes, and you can see that this clot in the right atrium has now transitioned over to the right ventricle. Now you could ask, what am I doing with this case? We're actually doing this in the OR because when we remove these large thrombuses that go from the renal cell all the way up to the heart, we tend to have a cardiothoracic surgeon and a urologist work at that at the same time. But this is pretty dramatic. So you can see this clot from the right ventricle has now transitioned over to the main pulmonary artery, and the heart is now in complete standstill. Norma Braun's on this. She'll say, I told you the right ventricle can't take acute pressure overload. We've known that for years, but here's a dramatic example of that, a sudden PE causing a sudden rise in pulmonary vascular resistance, causing the RV to be in complete shock. The surgeon opens the chest here, removes the clot from the pulmonary artery. You can see restoration of right ventricular function immediately. Once again saying the real key here is not giving epinephrine or maintaining the blood pressure, is finding the cause, going after it, and eliminating it so that you can stop the cascade. Once you've done that, obviously you can support the circulation, but I've also highlighted initiating effective therapy. And I think, we've spoken about that. I think the contributions of St. Luke's and the cardiology department and Dr. Hockman in particular to this field is absolutely immense. This is clearly one of the most important trials ever done in cardiology. And it really established for the first time that in the setting of an acute myocardial infarction causing cardiogenic shock, you had a mortality difference of 13 lives saved per 100 treated at that time. And now, while it's something that fellows might consider routine, you really should be aware that in the 1990s, when balloon angioplasty was at its infancy, we really did not take these kinds of patients to the cath lab. And it wasn't until we did the shock trial that we took these near moribund patients for emergent surgery or emergent PCI with a dramatic impact on lives saved. And these folks went on to have really quality lives in the decade ahead. So not only did we save lives, we also maintained quality of life in these patients in whom we did revascularization in the setting of shock. But not everything with revascularization has actually worked. In the years since, we've also realized that when we do see people with an acute myocardial infarction and shock, we always treated the infarct-related artery based on the shock trial. But based on the benefits of CABG in the shock trial, we really thought that treating remote ischemia, performing complete revascularization in these patients was very, very important and should be considered because many of these patients have multivessel disease. This is work from Holger-Thiel showing whether a routine strategy of doing multiple vessel intervention in the setting of shock was indicated. Most people would have thought it was, but in this very large randomized trial of nearly 700 patients, you can see that a routine strategy of performing multivessel PCI in the setting of cardiogenic shock due to myocardial infarction is actually associated with increased harm. And so our current strategy with shock based on this trial in the setting of an infarction is to open up the infarct artery, and we would only do revascularization of the non-infarct artery in select patients, and who those patients are, I think we can discuss at another forum. The one other thing that we did realize from this was that the intra-aortic balloon pump in patients with shock, undergoing revascularization really did not seem to improve outcomes when used routinely. Now, this is really important because when we did the shock trial, we actually recommended the use of an intra-aortic balloon pump. And so the use of an intra-aortic balloon pump in the shock trial was more than 90%, even in the conservatively treated arm. And the reason that was done was because we did not want the benefits of revascularization to be surrogately bound to the placement of a balloon pump in the treatment arm. And so that was a strategically really important thing to do. But what we realized from the SHOCK 2 trial was that when you are in shock and you've got profound decrease in stroke volume, even after opening up the artery, then the addition of an intra-aortic balloon pump in those patients really did not mean much. And so we've started using these newer devices more and more in the setting of shock after an acute myocardial infarction to provide support. And that's changed what the CICU looks like. Because of these devices now, there's a large proportion of the patients in a CICU, because of the availability of temporary mechanical support, are now being bridged to a decision. So our concept of how we manage persistent shock, no matter what the situation, is obviously to identify the cause, but recognizing right away that there is some futility in a small proportion of patients. Recognizing that futility is important, but is also extremely challenging. But it really does not make sense once you recognize futility to throw the chicken sink on somebody, use all these costly resources, use significant physician nursing time, and really give the family a ray of hope where there is none. So I think calling futility in some patients with shock early remains appropriate. But for the vast majority at 3 in the morning, we're not able as cardiologists to make that decision. What should we do in that situation is bridge them. Let's say in the setting of an acute myocardial infarction, we revascularize the artery and we bridge them to support. And we bridge them to support with one of the devices that I showed you, either a left ventricular device or a right ventricular device, or in profound shock with an VA and ECMO, with an intent. The intent is to buy time. And with time, we are able to make more rational decisions. For those whose ventricular function does not improve or whose underlying condition cannot be salvaged, we then withdraw care. For the handful of patients in whom the ventricular function recovers, the young man who committed suicide and has a profound LV dysfunction that's going to recover with dialysis or with time of removing the drug, we wean those patients off. And then for the others, for the 45-year-old man who's had a proximal LAD infarction, who presented late, in whom we've opened the artery, we can't salvage the myocardium. They have a heart rate of 120 without support. Their blood pressure is 60. They got end organ hypoperfusion. We consider advanced options like an LV assist device or transplantation. Now, this group is actually a very small minority. In a large proportion of patients, bridging still leads to withdrawal. And so while we keep trumpeting all of these devices and all the promise, the challenge of survival after cardiogenic shock remains a huge unmet frontier in both interventional cardiology as well as in critical care cardiology as a whole. And I do think that in showing the cases that we salvage thanks to these devices, we sometimes make the lay public and our physician colleagues feel that we've really transformed the management of cardiogenic shock, which we haven't. We've certainly made advances, but we have a long way to go in this setting. So let me show you what that concept is for the residents in terms of bridging versus weaning versus support. So let's take 2 patients who come in. This is before we knew about COVID. We also had a disease called influenza, and influenza did significantly impact young people. It's obviously been amazing how in the current era with masking, we seem to have cured influenza this winter, and we hardly ever saw any. But this is a young man who presents with sinus tachycardia, and you can see there's ST elevation in the infraapical leads with some PR depression, consistent with acute pericarditis in the setting of the viral infection. You can see when you do enzymes on this patient that the patient does have elevation in their MB and troponin, suggesting that this is not a simple pericarditis. This is a myopericarditis because both the pericardium and the myocardium are involved. When you take a look at the ventricle, you can see an edematous ventricle with a small pericardial effusion, with pretty severe LV and RV dysfunction. And this patient is in profound biventricular shock. So you go on, in this case, young person, significant opportunity to recover, end organs still intact or can be recovered. Easy decision, you bridge the patient onto an ECMO, buy yourselves time, and 3 or 4 days later, the ventricle has completely recovered to normal. This is a case of fulminant myocarditis. This person is going to live the rest of their lives with very little sequelae of this encounter. No end organ injury. This is where these devices have completely revolutionized care. Now, all viral myocarditis does not end that way. So here's another person with influenza myocarditis presenting. Actually, this was about 3 or 4 weeks after the first one. And you can see in this case too, the left ventricle is dilated and dysfunctional. There's a trivial pericardial effusion. The right and left ventricles are both very, very hypokinetic. This person is in shock and was also placed on an ECMO with the same intent. Now, when you go back in time, this is 7 days later, the patient is still on support. We're trying to wean this patient off support. We have a TE probe, which is why the echo images here look different. You can see that unlike that first patient, the ventricle has not recovered in this patient. In fact, what you see as cloudiness in this left ventricular cavity is basically rouleau formation from stasis of the blood. And this person is completely dependent on the ECMO because they have no RV and LV function. So in this case, we cannot wean. This is a young patient. We're not going to withdraw. End organs are intact. So we say we're going to transplant this patient, and this patient goes on to a transplant. And you can see from a transgastric view, this is a transplanted heart with normal LV function. And that's one of the miracles of modern medicine. We can do things like this for select few individuals who go on to benefit. But clearly, these devices have helped us implement that thought process. And so that's really important to recognize. The question here, like I said, is a lot of people don't recover. And this so-called weaning and bridging strategy to definitive treatment works in only a minority of patients. The truth is a lot of patients who present with shock, regardless of their etiology, end up dying. And so how do we move the needle further? And let's talk about some developments that we see forthcoming and have already been implemented in many institutions around the country. I think the first thing is in trying to do more meaningful research. So why I say that is shock is a pretty subjective phenomenon. Is shock because someone has a VFib arrest while I cannulate the right coronary and is getting defibrillated right away, the same as someone who has an out-of-hospital cardiac arrest and has 45 minutes of CPR? It's certainly not. And so we recognize that. But in most data sets, the shock comes in various flavors. And all of us know that some of these flavors have a more favorable outcome than others. And so this was a recent attempt at trying to get a more meaningful classification within shock of putting people into buckets so that when we compare apples and oranges, we are really comparing apples to apples across institutions. People always talk about the lack of randomized clinical trials in shock. And there will be randomized clinical trials because it's very, very hard to randomize patients in this setting with out-of-hospital cardiac arrest and various other things across the country with a proportion that is going to provide meaningful research. And so at least trying to compare registries across institutions is very important. And so I don't want to be comparing Class C patients in one institution to Class E patients in another registry and say the outcomes of one procedure is better than the other. And so this was a recent SCAI classification where it divides people in shock into those with classic shock, those who are deteriorating, and those who are in extremis. And in many ways, this is quite helpful. This is a study done by Jake Genzer from Mayo Clinic that I was happy to be part of and help with in a very small way. But what he did was he said, does this theoretical classification that the SCAI group has actually put up really work in real life? And so he looked at patients admitted to the Mayo Clinic CCU over many, many years and classified each admission into one of these 5 groups of incipient shock or manifest shock. And you can clearly see that using that crude clinical classification, you really get a graded mortality rate, and that patients with Class C shock are very, very different from patients with Class E shock. So it's important when you're doing a journal club or something like that, that you really look at 2 studies and really see whether the patients actually studied. Not the patients intended, the patients actually studied, whether they actually mirror the intent of the trial and whether they're actually comparable to the patient in front of you. Because that's what it's all about eventually, is making decisions in the patient that you have in front of you and doing it to the best of your ability. The other major advance that we've realized in shock is that we need to implement these devices early. We need to implement the right device in the right patient, and we need to do it quickly. And obviously, many of these patients present to very small community hospitals out there in rural America and in suburban America. And the question is, how do you get them effectively to large tertiary and quaternary centers that have these resources that I spoke to you about? And so for that, I think we've all moved to a concept called we create a shock team. This is a team that's available 24/7, 365 in most institutions. And shown here is a study by Tehrani, which really emphasizes, although with flaws, at least in an observational fashion, what the impact of creating a team, a shock team in the setting of this scenario is. And this is data from Inova Fairfax. And you can see that with implementation of a shock team, at least in their preliminary data, subject to multiple biases, there really appears to be an improvement in outcome for these patients. And you may say, why are they having an improvement in outcome? It may be because of earlier recognition. It may be because of earlier transfer. It may be because of earlier use of these devices. It may be because of more cerebral input from a multifactorial team. There are many things that could contribute to this. And so I do think that we've followed that kind of approach here at the Cleveland Clinic. And our goals have been to recognize shock early, to place devices as early as possible when we understand the mechanism, to clearly have these patients hemodynamically monitored so that we can follow them up over time, to minimize the use of pharmacotherapy because we think pharmacotherapy in this setting is limited and has marked side effects on both heart and peripheral organ function. But the ultimate goal is to get heart recovery with the end organs being protected. And so if you are in the Cleveland Clinic system and you were to call this number, actually, if you were anywhere in the country and you would call this number at any time of the day or year, you'd actually get someone like me in the CCU, an interventionalist, a heart failure transplant cardiologist, and a heart failure transplant surgeon online. And we would make a decision right then and there how the patient was coming to the Cleveland Clinic, what kind of devices we need to support, where we would meet them, and how we would implement the plan going forwards. And I do think that while there are some disadvantages to this, the advantage to having this strategy is very early, decisive plan in terms of what support to put under what conditions, and very early involvement of the possibility of getting a bridging strategy moving on to a durable VAD if that is a potential case. And so this is just a general schematic of how that would take place and the people involved in it. So let's put that together in a kind of scenario that you and I have been unfortunately very, very familiar with in the current era. We'll say, how does a shock team work in this situation, and show me the promise of a shock team. So there's a prison in the middle of Ohio. It's one of the largest prisons in the state of Ohio. And sometime early on in the COVID outbreak, maybe in around May of last year, they had a huge COVID outbreak, hundreds of patients with COVID. So we get a call in that situation that one of the inmates in this prison, and you can see why I'm bringing up this case, because this is clearly someone who is vulnerable, right? They're in a prison, they're a prisoner. We obviously intend to give them the best possible care, but they're a very vulnerable population. So this guy has classic history of a loss of taste for 2 weeks. He's had 2 to 3 weeks of fever, and then he goes into a rural hospital there. He was very active prior to being incarcerated, running 5 to 10 miles. But when he goes into that hospital, he is in big trouble with a white count and all of the other issues that you guys realize here in a setting of COVID. A marked procalcitonin, a marked elevated D dimer, highly activated, elevated interleukin-6 levels, a myocarditis with a troponin being elevated, and obviously all his respiratory panel being negative, and as we would suspect, and remember, these are the early days of COVID, the guy is COVID positive. Here's the EKG, and you can see here the EKG has very low voltage across the board. And this, in the setting of the prior history, either suggests a guy with a known dilated cardiomyopathy, or it suggests severe edema in the context of myocardial inflammation, which this person has. The chest X-ray actually shows a relatively mild congestion and really no evidence of a COVID pneumonia. So this person is really manifesting with signs of shock without a COVID pneumonia. And here's the echocardiogram. You can see that the left ventricle, like that influenza case, is shocked. It's not very dilated, but there's severe hypokinesis. And the right ventricular outflow tract shown here, or the RV shown here, is dilated, dysfunctional, with very poor coaptation of the tricuspid valve. One would think this is a chronic condition with severe tricuspid regurgitation. And so this person has a markedly decreased cardiac output with a profoundly elevated lactate and hypoperfusion in this setting. Now, having a shock team, you're able to bring this patient emergently on a helicopter from this rural penitentiary in central Ohio to the Cleveland Clinic. And even while the patient is being transferred, we've looked at the initial echocardiogram and said, as soon as this person comes to our institution and lands in the CCU, we're going to take him to the procedure room, place a VA ECMO, because this person has both right and left ventricular support. We're going to put a femoral impeller in because this person needs to have the LV decompressed. Go ahead and put a PA catheter. And in those early days, we were certainly using tocilizumab whenever we saw activation like this. And so when he came in, obviously, we supported him in this fashion. And because we won, it was atypical. It was the early days of COVID. People were talking about COVID myocarditis, but there were things here that were bizarre. The QRS complex was a little wide. We wanted to make sure we weren't missing something like giant cell myocarditis. We certainly proceeded by the bedside to do an endomyocardial biopsy. And so you can see here, we're using the biotome in the CCU under echo guidance to actually take the biotome to the interventricular septum and do a biopsy of the myocardium, just to make sure that we have an established diagnosis. Here's the histopath of that. What you can see on the histopath is a significant lymphocytic infiltrate, but you would see that with a number of viral myocarditis. But what was really fascinating to me is shown here under electron microscopy is you can see the coronavirus in the myocardium actually there, like a prisoner walking out in this situation. So clearly, this was the first demonstration of a coronavirus virion within the myocardium of it. So I thought it was fairly interesting. So we support this patient. And you can see, like that first case of viral myocarditis, with support, this person improves. And shown here is a left and right ventricle that look dramatically has normalized. And the right ventricle looks so normal here. The tricuspid valve is coapting once again. There's hardly any tricuspid regurgitation. This person has really been salvaged and was ultimately discharged from the hospital without any sequelae. So what I have highlighted here is few of the things that I think are critical when you have a patient with cardiogenic shock. One, understand why. You have to understand why. While you're understanding why, you have to support end organ function, the brain, the kidney, the liver, and the circulation. When you're doing that, the way you do that is by bridging folks. You have to get a team involved, a team that has got both critical care skills, but also has the ability to make decisions about long-term candidacy for withdrawal, long-term candidacy for durable support. It needs to have a palliative care person if you're going to go in a futility direction. Sometimes, like in that first case that I showed you, maybe you need a bioethicist when it's a vulnerable population or someone from a prison. What you do need is a multifactorial team. And I think if you do that, I don't think you're going to save dramatically more lives, but you will save a handful of lives who would otherwise never have survived without these devices. As we go forwards, I think we need to still work on reducing mortality with shock. We still have a whole lot of work to do with early recognition, early intervention. You know, we are blessed in the US, we have so many tertiary institutions, but we all see patients every day who we say, I wish I'd seen this patient 2 days earlier. I wish someone had recognized that this aortic valve is hanging in the breeze with aortic regurgitation and send this patient for surgery. This happens all the time. And so I do think the challenge here is to really create systems of care that allow these vulnerable patients the best chance to get the appropriate treatment and get the appropriate outcomes. And in that setting, you know, I think the field of critical care cardiology is really going to blossom, because for many years, you know, we've concentrated on reperfusion as the only reason to have a CCU. And now our interventional colleagues do such a good job. We ask the question, does anyone who gets a primary PCI and has STEMI 3 flow in a low risk situation even deserve to enter the CICU? We need those beds for so many other patients with end stage heart failure, ICD storm, out of hospital cardiac arrest, major pulmonary embolism. It's just enormous, that population. And so let me stop here and I'll take any questions. I see Dr. Narula on the call too, and he's obviously been a significant supporter and helped me on so many things over the years. And I think to see him and to see cardiology being led by him at St. Luke's is also very gratifying, because I take great pride in the fact that I trained at St. Luke's Roosevelt. And you know, there are people there, just take anything. If I, the little bit I know about nuclear cardiology, I know because of Alan Rozansky and Gordon Dupuy. The little bit I know about the CICU, I know because of my time with Judith Hawk. I'm not very good at cardiac catheterization, but I can cannulate a right coronary, and I owe that to Jim Slater and Angela Palazzo and Bob Lever. But I think the bottom line is I learned to be a good physician at St. Luke's Roosevelt. And I appreciate so much the opportunity to come back and give this talk. So thank you.
Thank you so much, Venuji. It has truly been an honor to have you here today for this Miles Schwartz combined cardiology medicine grand rounds today. And it is such a pleasure to see you flourish the way you have done and have led the CICU initiative and community so ably and so effectively. So it's truly, truly an honor to see you here. And I tell you that this lecture that you have given, so simply communicated, so easily placed. I tell you that all the residents and all the fellows, they are going to be remembering this lecture for all their lives. I mean, I'm very sure of that. And I personally was really excited to see that pathology picture that you showed from the COVID patient, truly with a virion sitting isolated in the interstitial space. And then you would see that the BNP was 70,000 while the troponin was only 0.4. And there is quite a lot of monocytes which are sitting in the interstitium with no myocardial damage occurring in spite of the fact that there are so many of the cells there. So it is very different than the viral myocarditis that we normally see. And this is probably one of the earliest cases. I absolutely agree with that statement that we have still been struggling whether we should even call it a myocarditis or what exactly it should be. But I tell you that this was such a wonderful example of it. And I have missed that if it has been published somewhere. And because I never saw that case, because most of the virions which are brought in there are brought in by the macrophages or the monocytes, or they are into the interstitial cells, but they never affect the myocytes. But the interleukins that they produce, and they are able to cause the leak of things like troponins and all, which is always at a modest level rather than anything else. So I truly will remember this picture myself, which you showed today. And I congratulate you for being able to do that and decide that you were going to go and get an endomyocardial biopsy. So thank you very much, and gratitude once again. Thank you.
Thank you, Dr. Narula. So appreciate it.
Thank you.
Thank you. Yeah, that was a wonderful talk, and I really appreciate it. But I would like to ask a couple of questions. One is, you showed beautiful studies of successes, and no matter what the studies show, there's always people who survive despite the worst cases, even though there may be very few. What are the factors in those individuals, despite the extremists, that allows them to survive? I mean, obesity is an epidemic problem, and obesity, depending upon its severity, even makes imaging less clear because of sheer mass. So, and then the volume distributions may be quite different too in those patients. So is that one of the factors? And then I hate to ask this question, but we keep having to deal with it, and that is the cost. The cost per patient survival, given the team, et cetera. I can't in any way dispute the utility of a shock team, because it's the rapid response that allows the decisions to be made that affects the outcome. So could you comment a little bit on, because the institution has to agree to make the investment in this type of coordinated program?
Yeah, no, I think you raise very relevant issues where cost is a significant barrier, and I think it's on both sides. If the costs, if you use it in a lot of people in whom there's futility, then the costs escalate. The devices are highly invasive. If you go and put it in too early in people, the collateral damage of putting these devices increases. So you have to find where that sweet spot is. I do think that one of the biggest challenges in acute critical care cardiology, like in most fields, is to have the ability to prognosticate what's going to happen to our patients.
Yeah.
You know, the only thing that goes very strongly is age. You know, that's going to be a factor no matter what. But anyone who's been by the bedside is humbled every day by the fact that someone they thought would not make it makes it, and someone who will make it does not. And so I think it is a very humbling decision for a clinician by the bedside, despite their experience, to make that dichotomy of I'm going to go all in here and I'm not going to go all in the other place, and be consistent on it. So this, I do think, is the biggest challenge, and I'm hoping that smarter people than me can figure out that. You know, we've done it in certain cases, but you know, when even in the shock trial, when we originally did it, the data suggested that patients over the age of 75 did not benefit. Now, there are hundreds of case series when cherry picking people over the age of 75 with a biological age and a quality of life that was pretty good before that, they get the same benefit. So we are always a little leery of denying care, but this will remain a huge challenge. And I think the cost issue is important because I can tell you from a Cleveland perspective, we get patients from rural Kentucky, rural West Virginia, the Upper Peninsula of Michigan, Western Pennsylvania. These are large rural areas. You know, if they, let's say you get 3 patients flown in from West Virginia and you put them on support, and West Virginia Medicare says, I'm not paying for this, you can close down a program pretty quickly from that perspective. So we're very aware of it. I think for now, I think we've just done the best we can as physicians, in the sense we've looked at individual outcomes, and whoever we think we can help as individuals, we've done that. But clearly we have societal responsibilities that I would hope that organizations like the ACC and the AHA and, you know, based on outcomes research will provide more data on and more fidelity for us to do that in a fashion. Because yes, what I am saying is, you know, you could be alive if you get admitted to the Cleveland Clinic. You may not be alive if you get admitted to so you're living by your zip code here, and we don't want that to be, that's not appropriate.
Hi, Dr. Menon. So we have a couple of questions in the chat. Actually, we only have one from one of the current fellows, Chandrasekhar. He's thanking you for the great lecture, and he's asking, can you please comment on the changing patterns of the use of Swan-Ganz catheter in the CICU? And do most of your patients who get an Impel device first get a PA catheter?
So I must say that, you know, different institutions have different flavors. And so at the Cleveland Clinic, we've always believed in hemodynamics. It's been a fundamental basis of anyone who comes into the CICU. So even before the use of these devices, I would say that if you were to walk into my CICU, 75 to 80% of patients at any time will have a Swan-Ganz catheter. And I think as cardiologists, we look at the O'Connor data from the late 1990s in using the Swan-Ganz catheter in a mixed variety of MICU patients, or the Swan-Ganz catheter in ARDS studies. You know, I know there is no positive outcomes data, but we find it clinically very, very meaningful to follow serial hemodynamics and to institute support guided by the Swan. And now that's been increased even further by the reasons to identify which ventricle to support and how to wean and all of these things. I think they need objective data. And so we think the right heart cath is an integral part of the care of these patients.
Dr. Menon, our fellows have another question, and they're in the conference room. They're going to mute themselves and they're going to pose a question.
Thanks, David. Dr. Menon, thank you very much for that talk. This is Aditya, one of the fellows. I know we saw in your talk that intra-aortic balloon pump is not something that is routinely recommended. Is there any specific phenotype of a patient that you keep in mind, or you have at the back of your mind, that you would consider intra-aortic balloon pump as the sufficient therapy, or as a therapy to go forward as the first device for that particular patient in shock?
Yeah, so I strongly believe there's a role for an intra-aortic balloon pump. We use it a fair bit even today. I think the patient. So, if the reason to put a device in, if it's something like mitral regurgitation, we would use an intra-aortic balloon pump. If it's angina and breakthrough in the setting of critical disease, we would still use an intra-aortic balloon pump. Where we would not use an intra-aortic balloon pump is if we find that we want 4 liters of support to keep this patient alive, then we would straight away move on to some other device. I do think that that's what I think these pumps was tested at. When you look at the IABP trials, they were all done in people who had an arrest, had an MI, had PCI, had opened the artery, and they were still in shock. And so the pump was more because the stroke volume was low, and it doesn't surprise us that it doesn't work in that situation. But anyone who's used an intra-aortic balloon pump by the bedside has a number of patients who will benefit dramatically from its use. And so especially one group that I strongly use it in is in somebody in whom mitral regurgitation is playing a significant role in their outcome. Again, in ventricular septal rupture, we might use it there too. But the mitral regurg space, I think, certainly yes.
Dr. Menon, we have a lot of comments in the chat, thanking you for a great lecture, ranging from primary care physicians, ID physicians. Dr. Shapiro is saying, thank you for a wonderful talk. We're very proud of having you as an alum.
Well, let me just stop you there. And, I don't know if I mentioned Dr. Janet Shapiro, when I used to be an intern, we used to be in the ICU one day. It was alternate day, night call. So you went in day one, you worked in the ICU, you rounded with someone like Dr. Shapiro till 1 o'clock in the afternoon. You went home and you came back and you were on 36 hours call. So you only missed 1 potassium in 15 days while you were there. But it was hard work. But working with someone like Janet Shapiro makes you just thank being a physician, because I didn't realize how young she was then, because I looked up to her as some person who was just someone who was like a guru to me. And it was just spectacular what her commitment to to MICU care was. And Janet did make me think, at least in those 3 or 4 weeks that I worked with her, whether I should do ICU pulmonary critical care.
Thank you, Dr. Menon.
Dr. Menon, thank you so much. We really just delighted in your talk and delight in the knowledge of all the wonderful work you're doing at the Cleveland Clinic. We certainly hope to welcome you back again in the near future, and we wish you all good things in the continuance of your wonderful work. Thank you again.
Thanks so much. I really appreciate the invitation. It's been a privilege.